Thanks so much. It's really nice to be back. I was trying to think the first time I went to like a UBC Grand Rounds, and back in the day they had this, I don't know if they still do, they had this Balfour Award where they gave it to people from either the North or the island to try and sort of sponsor their interest in urology. And I think they just created this award because they wanted Nathan Hogue to be interested in urology. And then I came a year or two after Nathan, and they like begrudgingly gave it to me. So I think that was the first time I came to a UBC urology round. So it's nice to come back. These are my COIs. They're mostly in prostate cancer, but not really in localized disease. So it won't really affect what we're talking about today. Well, anchor on a case. This is a guy who's actually from my clinic. This is a pretty typical 50-year-old guy, PSA of 15. Outside urologist goes straight to a truss biopsy. Our wait times are, I think, as bad as yours for MR. So many of the community guys will just go straight to a truss. He has grade group 2 disease. He has good function. So the question is, what do we do for him? I'm going to skip a bunch of the steps. So we're going to decide that he's got localized disease. You can argue about whether that guy needs staging or not. He probably doesn't. This, I think, is interesting. This is a bit historical. This goes back to the early 2000s. But the Institute of Medicine in the US picked 2 topics in urology that they felt were of societal level importance. And the 2 issues are, what's the best way to manage localized prostate cancer, and how do we deal with end-stage renal disease? Those are the only 2 things that we do in urology that the Institute of Medicine said were sufficiently prevalent and important to constitute public health level issues. And so we have the opportunity to do, by doing a better job on these domains, not just affect the care of our urology patients, but really have a societal level impact. So if we look at NCCN guidelines, these are the newest version. You guys are going to know surgery versus radiation with some hormones is the typical treatment paradigm. For this guy who has unfavorable intermediate, he barely has unfavorable, but it is. And that's based on life expectancy. So the question is, how do we best counsel these patients? And to do that, I think we have to take a step back and think about what is the goal of treating prostate cancer. And it may seem obvious, especially to like a junior resident, but I think the more time you spend treating these patients, the less certain you are about what you're actually trying to achieve. And so is the goal to live longer? That's OS. If we really think we're trying to affect OS, treatment decisions in this domain are really, really difficult. You're unlikely to show OS differences. Is it to cure disease? And if so, what's the metric there? How long free from biochemical recurrence do you have to be to have said that you succeeded there? This is one of my favorite Mark Emberton studies. You guys will probably know him about, the role of MRI pre-biopsy or questions around focal therapy. But him and Hash Ahmed did this very interesting study where they asked patients about the trade-offs they're willing to take in the management of localized prostate cancer. And they said, and this is, I think, the most interesting quote there, patients with prostate cancer report a willingness to compromise survival to achieve better quality of life. Patients are okay living shorter if they live better. So if we go back to living longer or curing disease, is that the goal? That may be a doctor goal. That's not really what the patients are saying they want us to focus on. So maybe if you're like me, you go down this very academic route, you want to think about maximizing quality adjusted life years. So things like QALYs, where you take into account quality of life and duration of life. And that's very nice for health economists, very difficult to operationalize in your clinic and actually inform patient care delivery with the quality metric. So this is a different measure, but assessing similar things to what Hash and Mark Emberton asked. This is an American survey where they asked patients, and on this side it's going to be low risk, on this side it's going to be intermediate or high risk, what they valued when they're making their prostate cancer treatment decisions. So curing cancer and preserving quality of life are both up there, and they're not that different in terms of importance. So oncologic efficacy, this is PROTECT data. We know that if we're looking for OS, we're looking for survival as an endpoint. This is not a disease where anything we're doing is probably going to make a big difference there. You can prevent downstream complications. And so that's where things like metastatic disease, ADT, clinical progression can be influenced by the addition of active therapy, surgery, radiation over surveillance. But we're probably not going to hit OS-based endpoints. for what it's worth, interrupt me at any time if things come up or you want to ask questions. So if we come back to this case, we can use an MSK nomogram. I don't know what you guys use when you're counseling your patients in clinic. I have this open like all the time, or you can use the EAU nomograms. You can use whatever you want. This guy's predicted, as long as he gets some form of active treatment, to live a very long time, right? He has a 97% cancer-specific survival at 15 years. And I think providing this information to your patient does a large amount to assuage their immediate anxiety peri-diagnosis, right? There's a 3% chance in 15 years you'll die of prostate cancer. That's a pretty reassuring message, I think. So then you go from curing cancer to the next most important thing, which is preserving quality of life. And you guys all know the considerations around localized prostate cancer. I think this is a very interesting table that comes out of a review paper that one of my mentors, Dave Penson, wrote, which just highlights the fact that there is a difference between objective symptomatology and patient experience or patient bother. So the way the questionnaire is captured is usually this bother metric. But the easiest way to contextualize this is, let's think of a man who's going to go for prostate cancer treatment, maybe has relatively poor erections to start with. His spouse is not that interested in intercourse, and losing his erections may not actually affect his quality of life that much. So his objective level of sexual function is going to be poor, but his bother from that may not be high. So there can be, not always, but there can be a disconnect between symptomatology and patient bother. And so objective measures of sexual function don't necessarily capture the patient experience and what they actually are bothered by or how it affects their quality of life. So this I throw up because it's fun, because it's a randomized trial, and because it shows things you don't think it's going to show. So this is an Italian trial where they compared robotic prostatectomy to brachytherapy. And this is continence. And what you see is that at every time point, after about 9 months, they're totally the same. And for potency, surgical patients always do better than brachy across the whole time. It's a bit paradoxical. I throw it up there because it's interesting. But what I want to highlight is that this is a bad metric. They use physician-reported outcomes. And physician-reported outcomes are essentially useless here. What you can gather in your notes with asking a patient gives you almost no understanding of what they're actually experiencing. So this is in the context of the HIPRO trial, where they're doing hypofractionated radiation therapy, and they collect patient-reported metrics, and they collect physician-reported like toxicity metrics, so CTCAE kind of metrics. And what you see is that the correlation between physician-reported and patient-reported is very, very low. Like the bottom end of the confidence intervals is almost zero, right? So importantly, it's not just a low agreement, but when you look at each metric, you got patient in orange, physician in blue. In many cases, patients are reporting things that doctors don't note at all. So there's not just a disconnect, there's whole domains of toxicity that patients are experiencing that their physicians are not reporting at all, which is to say that physicians are not aware of it in any way. So a physician-reported toxicity metric grossly underestimates the actual burden of treatment-related effect on our patients. And this is in the context of palliative medicine across sort of all aspects of care delivery. That was a prostate cancer specific example. But here you see that, the majority of symptoms are not volunteered by patients. They don't bring them up. So physicians are not aware of them unless you have a structured way of gathering these kind of symptoms. And when you have a structured way, you get 10 times more symptom reporting than if you just allow a natural clinical interaction to take place. So let's take that back into the localized prostate cancer space and use some objective metrics. So the most commonly used one is the EPIC. It's a bit counterintuitive when you try to interpret it because it's the opposite of the rest of our tools. So if you think of like a shim or an IPSS, high scores are bad, low scores are good. EPIC is the opposite. High scores are good. You start off at 100, and as things get worse, your numbers go down. So everything is backwards from the way we use our other tools. So the higher you stay on these curves, the better the patient is doing. Dips down actually indicate impaired function. So this is the first report of the CSER cohort, and we'll talk more about the CSER cohort and how we derived it later. But this was 3-year data, came out in 2015. and Dan published this. So this is looking at first urinary incontinence and then below sexual function. And then we see irritative symptoms, bowel-related symptoms, and hormonal function. And then we go from 3 years, we go to 5 years. We see the data reported a little differently, but similar conclusions. We know that we have PROTECT data in the similar time frame. We can contrast pros and cons of the different study designs. This is obviously randomized data. And you see similar things where trends over time differ from early trends. And we'll come back to it, but the conclusions you make in the first 3-6 months, even 3-5 years, may be different than long-term. And we have to remember that at 15 years, there's only 3% chance this guy's gonna be dead of prostate cancer. So we have to think of long-term trajectories to consider their actual treatment-related toxicity burden. So to be a little bit simplistic, this is how we viewed the rationale for our ongoing study, which is to say that there are a lot of studies looking at prostate cancer outcomes and prostate cancer patient-reported outcomes even. And as of the start of last year, I would have said we have a lot of studies with long-term follow-up of outdated treatment. So the prostate cancer outcome study accrued in the 90s, has nice 15-year follow-up, but used, best case scenario, 3D conformal radiation. Mostly it was using 2-box technique, big open prostatectomies, high toxicity, but long follow-up. And conversely, we have more modern treatments. So Caesar had things like robotic prostatectomy and IMRT as the standard treatment approaches, but relatively limited follow-up, 3 to 5 years, which in my opinion, in localized prostate cancer isn't enough to really assess the burden of disease. So we tried to bridge that gap with a longer follow-up of more modern treatment. And this is important because this data comes from prostate cancer outcome study. What you see is that the conclusions you would draw are different based on your time interval. So, for example, this is sexual function. If you look in the first 6 to 12 months, there's a big gap. And then the longer you wait, the less the gap becomes. And one of the confounding features here is obviously age. Time is an important factor, particularly for sexual function. So the other thing we want to add is not just 2 active comparators, but a real comparator. So we added a surveillance arm to look at natural trends and add that in as a comparator. So this paper came out last January. Bashir and I sort of worked on it together. He's now at Cornell doing very similar clinical practice to me. So Caesar, you guys, is a very interesting study design that I think we should try and emulate in Canada. I've tried a little bit. I think it's going to be hard, but I want to talk you through why I think it's so cool. So what happens is at these 5 different SEER registries across the US, so there's LA, there's Utah, there's Louisiana, there's Atlanta, and there's New Jersey. There's rapid case ascertainment. That is to say, you do a prostate biopsy, the cancer diagnosis gets recorded by the cancer registry within days. And then when that cancer diagnosis is recorded, it gets funneled to the research team who says, there's a new prostate cancer patient that meets our inclusion criteria. And the team, and I wasn't involved in 2011, would reach out to the treating physician who did the biopsy and say, is there any reason why we can't contact your patient? And if there was no response, or if they said, no, there's no reason why you can't, then the research team would reach out directly to the patient and do patient questionnaires. And the goal here, the reason why it's important is we want to get true baselines. We want to have the function after they're diagnosed, but before they go on any treatment. I don't know what BC's current cancer registry is like, but in Ontario, we have like about an 18-month lag before we can see any meaningful data. So like my other population-based studies, when we do them, I can get good Ontario Cancer Registry data up to about the middle of 2023, maybe the end of 2023 right now. So we have a big lag. And I think if we can bridge that gap, and there are some approaches we're trying to take to do it, we can do a lot more patient-directed and patient-centered research if we can identify them much earlier on. Otherwise, we're just reacting. So these patients got surveys at baseline, at 6 months post-diagnosis, 12 months, 3 years, 5 years, and then 10 years. This is what the cohort looked like. There's about 1,900 patients we grouped into what we called favorable risk disease. So at that time, we're talking about low risk plus favorable intermediate risk. And there's about 550 who had unfavorable, so unfavorable intermediate or high risk disease. And this is a breakdown of how the treatment went. This is a relatively good representation, I would say, of fairly modern practice. So you have about 80% robotic surgery of the external beam. About 90% of it was done via IMRT. ADT use was not mandated in the context of the trial. This was obviously a prospective but observational study. And so this is how it was recommended. And we analyzed it, taking this into account. But this is the cohort. We used EPIC. So EPIC, as we talked about already, is scored from 0 to 100. Higher scores are better function. This is our diagram. The essential thing that you'll see is that about half of men that you tried to approach at the top didn't answer you. That still is pretty good, I would say. For a cold call from our research team after you've just had a prostate cancer diagnosis, about 50% of men answered this like enormously thick book of questions. There's like a whole battery because we had like a psychologist and a bunch of other people involved in the research team. So there's like an enormous battery. It's like about 2.5 hours to fill out all the questionnaires that the research team sent at the baseline point. And about 50% of men actually did it, which I think is actually quite remarkable. In terms of surveillance, I think this is interesting. This is potentially actionable in terms of counseling. Even in 2011 in the US, transition to active therapy and surveillance was quite low. I think this reflects the fact that they were a bit selective in the patients they first put on therapy. But even at 10 years, we're seeing less than 30% transition to active therapy. That's below what you see in PROTECT, below what I have typically quoted my patients. I don't know what you guys are quoting. I often say, at 10 years, there's a 50-50 chance whether you'll stay untreated or need to convert to active therapy. The numbers here are actually a little bit more favorable, perhaps reflecting that initial selection bias where they're a bit more selective and they did treat some low-risk disease actively up front. Now, when you look at the one of the big takeaways here, and we'll walk through the data, is that you can't provide a comparison between treatment modalities independent of risk. I think that's one of the big takeaways. So when you counsel a patient with less aggressive versus more aggressive localized disease about the pros and cons of surgery, radiation, surveillance, those conversations have to be different. Whether you need to add ADT with the radiation changes the nature of the conversation in ways that are meaningful. And so in the context of favorable risk disease for sexual function, what you'll see being the red line is that prostatectomy takes a big hit up front, as we all know. And then by about 5 years, it's not really significant. And by 10 years, it's essentially numerically equivalent. So the interesting line, I think, for counseling is to look at this yellow one. This is surveillance, and we did a sensitivity analysis where it was only untreated surveillance. So people who hadn't been exposed to any therapy, they weren't part of that 30% who got converted over to active therapy at some point. And the takeaway is the same. So like age does a big amount of the hit here. So a large part of this is just aging. And you see that even in the radical prostatectomy curve, it takes a hit, recovers, and then it follows the same age-related natural declines that all the rest of the curves do. In terms of continence, no surprise that in the favorable risk group, patients who have surgery do worse, and it continues to do worse. Now, we were talking at dinner last night. These are not RETSIA-spared prostatectomies. They're robotic. I haven't read everybody's Orno, but I can almost guarantee you that they're not RETSIA-spared back in 2011. So maybe we can do better here, but for the time being, these data show a fairly sustained drop, which I think is interesting. In my own clinical practice, I would say, patients see an effect early on that seems to get better somewhere by, 6 months maybe. And then by a year, I feel like people are between the 6 and 12 month, we see continued improvement. But here, we don't really see that data. It kind of plateaus earlier than I thought. Irritative function. Interestingly, with more modern radiation approaches, external beam doesn't appear to affect the bladder today as much as it did in the past, although brachy still takes a hit. And Ballon hormonal functions, if you don't need to give hormones, you don't take to get hormonal functions. And importantly here, for more favorable risk disease, the radiation oncologist can tailor their margins a bit tighter, right? Their clinical treatment volumes or CTVs are tighter, and so you get less bowel effects. And we're going to see as we move to the unfavorable risk disease, where they give themselves a wider margin for oncologic control, you get more adjacent organ toxicity. So when we move to unfavorable risk disease, this to me is the single biggest difference in terms of how you counsel patients. It's maybe not surprising to you, but in terms of sexual function, if your patient is going to need ADT, even 4 to 6 months of ADT while receiving radiation therapy, there is no sexual function related benefit to radiation over surgery. So what's interesting is that even when we try to stratify by duration of ADT, you're going to see when we look at hormonal function, these patients are not recovering late. Now, obviously, there's some selection biases here, but what's interesting is if you look at about half the cohort reported erection sufficient for intercourse at baseline. And if you had an erection sufficient for intercourse at baseline, your chance of having an erection sufficient for intercourse during your follow-up is pretty well equal whether you had surgery or radiation. But the takeaway here is that it's not very good, right? So your odds, even if you have good erection at baseline, if you have unfavorable risk disease, whether you get surgery or radiation, we should be quoting people somewhere around a 20 to 25% chance that they're going to have an erection good enough for intercourse after their treatment course is done. Now, obviously, there's things we can do to get that sexual function back post-treatment, but these are the numbers that I am quoting to my patients today.
So if you do a nerves, then you have
So this is population. So we can talk about how I apply it to clinical counseling. So the answer is that the vast majority of the patients in the favorable risk got bilateral nerve spare. In this, it's a bit more mixed. You can do sensitivity analyses. It obviously shifts a bit, but it doesn't shift as much as you would think it would. My approach to counseling is I give these kind of population-based data to say, like, here's the groundwork, here's what's published. And then I think most people who are high volume prostate surgeons should know their own results and should be able to say, like, you know, in my patient population, in general, we see this, which is, and how it differs a little bit from the general population. And then you should be able to say, based on your specific characteristics, here's how I think it fits in. So for example, you know, you've got a guy who takes the occasional Cialis preoperatively, has unfavorable risk disease, has some bilateral disease. He maybe has a median lobe. Maybe the MRI shows an apical tumor. You're going to say, you know what? I'm probably not going to be able to get you the best nerve spare. Your function's already is already impaired at baseline. You're needing a PDE5. Your post-treatment sexual function is probably going to be quite poor. Conversely, you have the young 50-something-year-old who has a small gland, maybe an anterior tumor, and you think you can go wild on a nerve spare. You can say, you know, this is the average result, but I think for you, for specific reasons, we can probably do better than average. Things like that. And I think so I apply 3 levels of data when providing the patient expectation is, you know, here's the published data, the general sense of where the, you know, community sits. Here's how I know that my data fits into that context. And then in the context of your specific clinical situation, here's the ends of the spectrum I think you might be on. You might be to the more favorable or less favorable end of the spectrum. You can do the same thing for continence, right? The guy with a big gland, he's kind of overweight. You're going to counsel him to expect a poorer outcome potentially compared to the thin guy, small gland, you know, no median lobe. And so you can, I think, use those 3 tiers of information to provide the best sort of information with your counseling. And that's at least how I did. I don't know how you guys provide your sort of clinic counseling. Continence, unfavorable, still worse. The delta here is the same as it is for favorable, which is interesting, which suggests that a slightly wider resection is balanced by probably a wider radiation treatment volume. And the delta between the modalities is the same, whether the disease is more or less aggressive. Irritative function in general, not really affected by more modern treatment radiation modalities. There is some burning effect, but that's a bit of digging. I would call that post-hoc. I wouldn't put a lot of weight in there. Bowel function does take a hit in this patient population. And so I don't think this is about the ADT. I think this is about the wider treatment margins that rad-oncs want to use for more aggressive disease. And so you do see it. The effect is relatively small, but it's there and it persists. And interestingly, it persists out to 10 years. So this is long-term impaired bowel function. And hormonal also. So the average patient in this cohort got 6 months of ADT. and the hormonal therapy or the hormonal effects of that therapy persist out to 10 years. There was great data presented out of Montreal at GU last year in the radiation trials showing that at least a third of patients who get short-term ADT with localized prostate radiation never recover to eugonadal testosterone. Most of them don't get to eugonadal. That means that's not where they started. Most are well above eugonadal. We're talking like above the minimum cutoff of the assay for your lab. So whatever, every lab's a bit different, something in the range of like 12, 15. Like they're not getting up there. If they start at 27, they're still not getting up to 12 or 15, at least a third of the time with short-term ADT. And there's a recent individual patient data meta-analysis that Dan Spratt's group put out that has essentially the same conclusion. So I think the effects of ADT long-term in our localized patients have been a bit underestimated. This is a summary. The big takeaway, I would say, for patient counseling is that you need to tailor your counseling around the comparative risks of treatment modalities to the patient's disease characteristics in a way that prior studies up until Caesar didn't do, because really the risks associated differ based on patients having more or less aggressive disease, and the way you counsel is different. And the big takeaway, for me at least, maybe this is my surgeon bias, is that in the unfavorable risk group, the sexual function is the same between surgery and radiation. There's no sort of sexual function to be spared by taking a radiation-based treatment approach if ADT is going to be part of the recommended paradigm. So if we circle back to our question, what's the goal of prostate cancer treatment? Let's flip it. How could we think about doing this wrong? So if we screw up and miss our goal of prostate cancer treatment, what's going to happen? And in my mind, we need to think about what contributes to quality of life. So we can easily measure, easily is a relative term, measure these patient-reported outcome metrics. And that's what I've spent, 20 minutes talking to you about. There's adverse events, which are the easy CTC things to catch, readmissions, UTIs. But there's this big X factor, and there's all the other burden of being a cancer patient and getting cancer therapy. And trying to understand that contributes to what we think of the burden of therapy and what patients actually experience. And so the way I looked at this and wanted to operationalize this was the idea of treatment regret. And my feeling was that if a patient 3 or 5 or 10 years down the line after their treatment regretted it, then we had not done the right thing by them. Now, clearly, someone is always going to have some regret. It's impossible to alleviate regret for everyone. But as a general principle, the more patients are regretting their choice, the more we need to reconsider our approach, I think. And I think what's nice about regret is that it's this integrative outcome. There's a lot of different reasons why you might have regret. And so you could have regret because your cancer outcome didn't turn out the way you thought, or you had more toxicity than you thought, or some other characteristic. And so it provides a way to integrate all of the clinical outcomes that can happen through a patient-centered lens. Because as we talked about before, if you have bad sexual function, but you don't care about sexual function, you won't have regret. And so this is a way to allow the patients to prioritize their outcomes in a way that says, this matters to me. Because if you have regret, it matters. If you don't have regret, then it probably is less important for that individual. So this is a paper we published right at the end of my fellowship where we really dove into this. And so this is the conceptual framework, was essentially that we would have all these patient characteristics, and this would feed into pre-treatment expectations and their PDM, which is participatory decision-making style. The way they think about making medical decisions influences that. And that, along with their tumor characteristics, drives their treatment choice. That leads to functional outcomes that we just reviewed, and that, in the context of their expectations from before and their social support, helps contribute to whether they develop regret or not. So this sets you up for the methodologists here. You can do a mediation analysis. This sets you up with all these indirect and direct pathways to think about whether there's mediating effects. And anyone who wants to talk methods, we can go over that. So overall, 13% of our cohort expressed clinically significant regret. So there's a guy named Jack Clark who developed this scale specifically to look at regret in localized prostate cancer patients, has validated it out the wazoo. And this is clinically relevant, validated levels of regret. So that's 1 in 6, roughly. 1 in 6 to 1 in 7. So I'll put it to you, you don't have to answer, but do you think this is good, bad, medium. So this is at 5 years. We looked at it at 3 years. The correlation between 3 and 5 year regret is very tight. So people form their opinions relatively early. And if you have regret at 3 years, you're unlikely to not at 5. And if you don't at 3, you're unlikely to develop it by 5. And we're looking at the 10-year data right now. So I don't know what you think. I think it's like, okay, a bit high, maybe. It varies by treatment approach. So the surgery patients have the most. The radiation patients, intermediate, surveillance, the lowest. Put this in the context. So shortly after we published, as European Urology is apt to do, they got someone to do a systematic review of the study right after we published ours. And they found that in the literature, we're pretty comparable. So overall rates in the literature, I don't know what these guys are doing, because their rates of regret are like 60%. But everyone else falls in this range between about 10 and 30%. And so I think, somewhere in that like 10, 15, 20, maybe percent is a good anchoring number to have in your head, and with some variation based on treatment approach. So the question is, does treatment effect mediate this? And so there's 2 columns here. So this is essentially risk adjusted. So this is age, comorbidity, race, income, base, tumor characteristics, so risk group, PSA, Gleason score. This adds in patient-reported outcomes. So what you see is that, interestingly, the results always go in the same direction. While patient-reported outcomes may attenuate the effects, it never obviates the effects. So there's independent effects we see there. And so first is the active treatment with a surgery or radiation in this cohort increases regret compared to surveillance. And what's interesting, though, is when we break it down by risk group. So what you see is that in the low risk group, active treatment increases regret. In the intermediate risk group, active treatment increases regret. In the high risk group, active treatment decreases regret. And that comes back to one of the things I said about different reasons to have regret. So at a 3 to 5 year time point, a low or intermediate risk patient is unlikely to have experienced a bad oncologic endpoint yet. At worst, they've had some biochemical recurrence, probably. And so the regret in these patient cohorts is driven by toxicity. Whereas in the high-risk cohort, I think, there's more regret driven by a missed window for cure. Patients who took surveillance approach missed the window for cure, their disease progressed, and now they are unhappy and they regret their choice to not get active therapy. And we'll dig into that a little bit more. So we go back to that, but I want to put this in context. This is the prostate cancer outcome study. This is essentially the same study as CSER, but it was accrued about 15 years earlier. And over 15 years, I would say we have improved the way we deliver prostate cancer treatment. I remember being a med student, which was not in 1994, but we were doing open prostatectomies, and the anesthesiologist would put in a central line, an ART line, and an IV. Some of these patients had autologously donated blood to bank their own blood beforehand because they expected to get it back. And that was, early 2000s, pre-2010. So 1994, they definitely weren't doing better than that on average. And in 2011, I can tell you that we were doing RALPs, and maybe it's not as good as the Restia sparing RALP today, but it was not the same experience as 1994. And so one of the things I want to highlight is regret hasn't changed. And that's because regret is not just a function of your endpoint. It's about your expectations, about what you thought was going to happen and a comparison of that to what you actually experienced. So as patients' expectations rise, we may rise to meet them, but as we improve, their expectations will rise again, and we're not making them any happier. So if we think about predictors of regret, all the typical ones you want to think about are at the top, and most of those are not significant. And I want to highlight the 2 outlying points at the bottom, which have odds ratios in the range of 5 or 6. That is the perception of treatment effectiveness compared to their expectation, and the perception of toxicity compared to expectations. So patients who thought their treatment was less oncologically efficacious than they anticipated, or much more toxic than they anticipated, those were the ones who got regret. So we come back to this overall number of 13%. If your effectiveness was much worse than anticipated, your regret level was 71%. If it was much more toxic than you anticipated, your regret was about 50%. So this is about expectations, not about outcomes. You can even do subset analyses among those who have very bad sexual function, among those who have very bad urinary function. And the functional level is not that predictive. It's their delta from their expectation to their functional level that drives the regret experience. So that implies that improving counseling at the time of diagnosis and prior to treatment can actually mediate regret much more than improving our technical approaches, and doing the operation better is probably going to have a smaller effect than doing the counseling better. And all the residents are going to hate this because this means you spend more time in clinic and less time in the OR trying to get better caring for your patient.
This one as well. I mean, basically those who have, or you're saying those that have more like side effect than they expected and or worse outcome than they expected, but I just looked at bad disease and patients with more side effects. So not really being
So what you see up here, so these epic ones here, this is the effect of the actual functional impairment. So you'll see that like bowel function is not significantly associated with regret. Urinary irritation is not. Urinary incontinence is mildly not significant. And sexual function has an effect, but not a huge effect.
And that's considered the bother.
Correct.
Okay. And in terms of cancer records,
So currently, recurrence is not in this data set. We have adjudicated so for what's worth, the paper's coming. It's going to be a podium at AUA. We went through the PSA trajectories of every one of these 3,000 patients and looked at 10 years of PSA data in a multidisciplinary group. We had Zoom meetings, 2 urologists, 1 med-onc, 1 rad-onc, looking at every patient's PSA trajectory for 10 years. So we have all that data. The biochemical recurrence outcomes and MFS outcomes are all going to be reported out at AUA. But the next step is, as you imply, to add oncologic outcomes as a predictor of regret. And so that is coming in the 10-year regret paper. So that is underway. The analysts are working on that, like literally currently. So the obvious thing is like, let's do better counseling. Why don't we use a decision aid? We'll build some tool. It'll counsel patients better. And this is a systematic review that says it may improve patient knowledge, but it has no effect on regret or decisional preparedness. So everyone's like, how do you fix this? And the answer as of today is, I don't know. I don't have a tool I can tell you to deploy in your clinic that's going to actually work here. This is a summary of about 12 different decision aids developed across a variety of different prostate cancer support groups, some developed by clinicians, some developed by patients, many developed in combination. None of them have shown an ability to actually reduce regret. And so as of today, I don't have a great answer to deploy, but I put the sort of counseling I do in this context, which is to say it's a bit of an iterative approach to decision-making, and you don't want to go too far prescriptive, I think, where it's paternalistic. I think we also at times swung a little bit too far the other way, where we were too hands-off and we said, like, here's the information, it's up to you, you just decide and come back and tell me what you want. And I don't know what it's like here, but in Ontario, a lot of the rad-oncs are like that. They'll see them for a one-time consultation, they'll give them the information, they won't set any follow-up, and they'll be like, well, if he wants radiation, like, he just has to call me. And so one of the ways I address this is I have repeated visits. And instead of having one enormously long visit, when you do counseling, I just have multiple visits. So I start this conversation at the time that I'm talking about a fusion biopsy, because they always want to know what the downstream effects are. So you have a little conversation there. They come back for their biopsy, after their biopsy for path review. You have a bit of a discussion there about pros and cons, and you're going to send them off to radiation. And then you bring them back after they've met with a rad-onc, and you have the conversation again. And maybe somewhere in there you had to order some staging tests. And so that added another visit. And so instead of trying to do one enormously long visit where you go through this, you have repeated visits over like maybe 3 or 4 times to go over the data. And I think some patients feel pressured to make a decision, but I go back to some data we published coming out of COVID, which shows that even for those with high risk localized prostate cancer, whether you're treated, 6 weeks, 3 months, 6 months, 9 months, or 12 months after your diagnosis, and in that time it was anchored on trust biopsy date, your outcomes don't change. your MCRPC risk, your METS risk, your prostate cancer specific mortality risk, and your overall mortality risk are not mediated by the duration of time between biopsy and prostatectomy in the context of a year window. You guys, sounds like you have wait lists kind of like ours, so that may be maybe a friendly message for your patients as well to give them a little peace of mind. But I am very explicit to say that, you know, we have data that suggests that delays in the order of magnitude of months is not likely to affect the patient's cancer outcome. I anticipate you living for years, probably decades after treatment. You're going to have to live with the consequences and potentially complications of that treatment. So take the time up front to come to a decision you feel truly comfortable with and gather the information necessary to do that so that you can live that life without regret. Because, you know, adding, you know, a treatment 3 months earlier is not likely to change your cancer outcome. But if you feel uncertain at the time you go in for treatment, it may affect your lived experience long term. So this is the context of patient-centered care. The idea here is that it sounds very fluffy. It sounds very soft science, as one of my partners puts a lot of the work I do. But what we know is that if you provide patient-centered care, you actually get better cancer outcomes because the patients trust you more, they adhere to your recommendations and your therapies more, and so you can actually improve disease-specific prostate cancer hard outcomes by providing a patient-centered care context. And that is a really important leverage of the therapeutic sort of relationship to improve patient outcomes. So we come back, these are things that patients say matter to them and how they rank them. I think what's interesting in the context of the US, but we have to think about as well as cost. So this is a study, I'm not going to put all the weight on it. This is from Protect. So this is essentially premised on the notion that you are not improving survival by doing treatment. That's the like underlying premise here, because this is our Protect data. And what Vidya Sharma, who's at Mayo, showed, I think he was a fellow, maybe a resident at the time, is that surveillance is cheaper for about the first 5 years because you're typically, on average, not treating patients. Some of them will get treated. But by about 5 years on, in the context of Protect data, for the healthcare system, it's better to do prostatectomies. It is more cost effective. Anytime you look beyond 5 or 6 years, to have prostatectomy as your default localized prostate cancer choice. I don't use this for patient counseling, but I think it's interesting to think about. So this is when I think we put it together, you know, if we manage prostate cancer well, because it's so common and because patients live for so long, we have an opportunity to provide a benefit, not just to urology patients, but a wider sort of community level benefit and by improving the quality and quantity of life for these patients. And that's sort of what I would like to close with. If you guys have questions, I'm happy to take them. But I want to thank you again for the invitation to come and chat with you guys.